Hello and welcome to today's training, Clinical Kung Fu Managing Anger in Children and Teens with Anxiety Disorders with Alison R. Alden, PhD, and Julian R. Pojas, Doctor of Psychology. I am Helen Heyman, Director of Programs at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's event. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You have joined the presentation listening using your computer's speaker system by default. If you prefer to join over the telephone, just select telephone in the audio panel and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenters by typing your questions into the chat panel of the control panel. You may send in your questions at any time. We will collect these and address them during the Q&A session at the end of today's presentation. You should also be able to access materials. If you are requesting CE, you will need to write down the CE code that is at the end of the presentation. I would now like to introduce our experts. Dr. Alison Alden earned her PhD from Northwestern University in Evanston, Illinois, where she focused on researching and treating anxiety. She also completed a postdoctoral fellowship at Northwestern Memorial Hospital. She has extensive training and experience in cognitive behavioral therapy for anxiety, OCD, and mood disorders, and integrates mindfulness and dialectical behavioral therapy into her practice. Dr. Alden has published several research articles and book chapters on anxiety, depression, and emotion regulation. She has also presented talks and posters to state and national professional organizations. Dr. Alden has taught in Northwestern University School of Continuing Education Studies. Finally, Dr. Alden is a member of the Anxiety and Depression Association of America and was the recipient of the highly competitive ADAA Career Development Leadership Program Award in 2014. And our other expert, Dr. Julian Pojas, received her doctorate and master's degree in clinical psychology from Midwestern University in Downers Grove, Illinois. As a licensed clinical psychologist, she specializes in the treatment of anxiety and related conditions. She is trained in cognitive behavioral therapy and exposure response prevention. Dr. Pojas has received specialized training and certification from the Behavior Therapy Training Institute at the International Obsessive Compulsive Foundation. Dr. Pojas has experience working in a variety of clinical settings in Illinois and California, treating a culturally diverse population. She believes in providing culturally appropriate treatment. Dr. Pojas has done several talks training mental health professionals and educating parents about mental health topics. Finally, Dr. Pojas is a member of the Anxiety and Depression Association of America, the International OCD Foundation, and the Asian American Psychological Association. It is a true honor and pleasure to work with these two professionals. I will now pass the screen along to Dr. Alden and Dr. Pojas.
Hi. Hi, and thank you for attending the webinar today. I'm Dr. Alison Alden.
And this is Dr. Julian Pojas.
And today we're going to be talking about dealing with behavior in kids and teens with anxiety disorders. And in doing this presentation, neither of us has anything to disclose. After this presentation, effectively manage tantrums and how to do so. Utilize rewards, concepts, hearing to overcome treatment refusal, and work with parents and schools to treat school refusal. Figuring out how to anger behavior common struggles for practice. Kids and teens often react with anger to the aspect of doing exposure response prevention. I'm going to pause for just a second. Helen, I can still hear the audio on your end. So if you could possibly turn that down, just because we're getting a lot of interference.
Yes,
Sorry.
I'm doing.
Okay. So like I was saying, figuring out how to deal with angry behavior is a really common struggle for the families that come to our practice. And kids and teens, often react with anger to the prospect of doing exposure treatment. And in some ways, this is a very natural reaction. I assume that most people attending the webinar today are familiar with the idea of the fight or flight response. Basically, the idea that when faced with some sort of perceived danger or threat, both people and animals react automatically by either running away or fighting. And the thing is that while we call this the fight or flight response, those of us who work with anxiety tend to really focus on the flight side. We tend to think more about our patients' avoidance behaviors and escape behaviors than we do about that fight side and anger. However, fight responses can really come up in the context of anxiety disorders, especially in working with children. Doing exposure and response prevention and going against their anxiety can definitely appear to be dangerous. Therefore, it makes a whole lot of sense that this type of treatment not only brings up anxiety for kids, but also anger and urges to fight or resist. That said, even though this is kind of a natural reaction, this type of reaction can definitely interfere with treatment, and it can definitely interfere with family life. So it's up to us as clinicians to deal with it and to help families deal with it as well.
So you know that the child's anger is a natural reaction because of their fight response, and they feel threatened in some kind of way. The big question is, what are the factors that specifically cause the anxious child to get angry and then act out? Parents will ask us, why does my child act like that? There are several reasons why an anxious child may be acting out, and this will differ for each individual child. I believe that a good assessment is one that includes a functional analysis to determine the function of the child's behaviors and what is maintaining their anxiety. Keep in mind that a child that acts out because they're anxious, uncomfortable, or scared does not mean that the patient is impulsive, defiant, or trying to manipulate you. Sometimes their behaviors can appear to be impulsive or oppositional, but they are not. It is important to not mistake their anxiety as ADHD or oppositional defiant disorder, and this is really important when diagnosing and especially during treatment because the treatment approaches do differ, with anxiety incorporating more exposure response prevention as the primary component to treatment. Anxious children have a strong need to avoid or do their rituals because they feel afraid and have extreme difficulty tolerating anxiety or some type of emotional or physical discomfort. They may be acting out as a way to stop a feared event from occurring. They may be frustrated with themselves because they realize their behaviors may not make any sense. They might feel guilty because they blame themselves for causing stress for parents and sometimes even the therapist. As a result, these kids are more susceptible to becoming depressed due to the anger that they direct towards themselves. Therefore, it's not surprising that children who have anxiety disorders may also have comorbid disorders like major depression, a learning disorder, or ADHD. So remember, there's a lot more than meets the eye whenever children with anxiety act out. The behavior may often serve a function for the patient to protect themselves from feeling worried, anxious, or scared. In some cases, there also may be some secondary gains such as video games if the child gets to stay home for acting out. More times than not, it is these two components, the need to avoid feeling distress and the presence of a positive reinforcer like access to a video game that are maintaining the tantrums.
So, speaking of tantrums, we're going to start out by talking about some basic behavior management techniques that can be used across situations when kids tantrum or act out. We'll then get into how to deal with particular types of situations that frequently come up, like treatment refusal and school refusal. So one behavioral issue that we see across situations is tantruming. Kids screaming, saying they hate you or their parents, crying, making verbal threats to themselves or others, hitting, throwing things, etc. And this can be pretty scary for parents. A lot of times families really feel held hostage by this type of behavior and are at a loss about what to do. Additionally, when this behavior comes up in the context of anxiety because the child is scared of doing something, parents also sometimes have trouble recognizing that their child is in fact having a tantrum. Many view it as merely a sign that their child is struggling and think that it means that their child needs help or accommodation. And tantrums can definitely be a sign that kids are struggling. That said, as I'm sure you guys all know, the best way to deal with anxiety is actually to stop accommodating it and at an appropriate pace to push people to face the things they fear. So before you even get into behavior management techniques, you may need to work with some parents to help them see this and to help them understand that their child's tantrums do need to be considered behavior problems, even when they're motivated by fear. Now, once parents are on board with this and with the idea of reducing accommodation, you should provide psychoeducation on tantrums. And the first thing that both you and parents need to understand about tantrums is that they need attention to exist. It's pretty unusual for tantrum behavior to continue if no one is paying attention. If you've ever gotten upset yourself or had angry outbursts, I want you to consider how long your own outbursts have lasted when you were by yourself versus how long they lasted when other people were listening and responding or even trying to console you. I would tell you that, generally outbursts, tantrums, that kind of thing lasts much, much longer if somebody else is paying attention. Therefore, you should instruct parents that paying attention to their child's tantrum, even saying something that they think is soothing or trying to calm their child down, often just makes their child angrier. It can give their child points to further argue against or further things to react to. Now, kids also continue tantruming because oftentimes tantrums work for them in some way. For a variety of reasons, ranging from compassion for their child to fear of what might happen if the tantrum continues. Parents sometimes give in to tantrums and give their child exactly what he or she wants. And this, of course, reinforces this type of behavior and makes it more likely that children will use this strategy again. So it's really crucial to explain to parents that giving into tantrums, even once in a while, actually makes them very likely to continue. To understand why, I want you guys to think a little bit about how slot machines work. Even if slot machines don't pay off very much, many people continue putting money into them over and over and over because every once in a while they do pay off. And that random once in a while payoff is actually a very strong motivator for behavior to continue for a long time in the absence of consistent rewards. For parents giving into tantrums, even once in a while is just like that. Even if parents don't do it very often, their child is likely to continue the behavior in the hopes of a random once in a while payoff. Now, in addition to sometimes leading to what they want, tantrums sometimes work for kids in another way. Having their parents focus on them and having their parents get all riled up themselves can sometimes be reinforcing for kids, especially when they're upset. So the treatment for tantrums, which is obviously a lot easier said than done, is to have parents stop attending to them. It's important to coach parents to literally not react to their child's behavior at all. The very best thing that they can do is to either just walk away from their child or to stand there like a mannequin, not looking at their child, not talking to them, not making eye contact while their child is tantruming. And they basically want to stay away from or refrain from reacting until their child is quiet and their behavior is under control. Now, when I teach parents how to do this, I typically have their child in the room with me, and I have the parent and child role play either a recent situation in which the child has tantrums or in which tantrums frequently come up for the family. And I have parents do the role play in a couple different ways. First, I have them do the role play with the parent reacting just like they typically do, saying whatever they would typically say, whether that's trying to console the child or yelling at the child, whatever their typical response is. Then I had the family repeat this role play with the parent reacting in this new way that I've taught them, really ignoring their child. And I asked both the kid and the parent to think about how each of these interactions feel and who it seemed like won each of these interactions, who had the upper hand here. And typically, when I do this exercise, both kids and parents tell me that the kid won the first interaction, typically because they were able to get their parent all riled up, while the parent won the second interaction. And I would tell you that I find it really, really valuable to have the kid in the room when I go through this technique with parents for a couple different reasons. First, just to do this role play because I think it's helpful for parents to practice. And second, because I really want kids to know what their parents are doing and why they're doing it when they start making these sorts of behavioral changes. A lot of times these are really big changes for the family, and I don't want this to be a surprise to the kid. Now, I realize that some of you may worry about damaging your rapport with your child patients by doing this in front of them and coaching their parents in this kind of technique. And I tell you that it's actually certainly true that a lot of kids don't like the idea of their parents ignoring them when they're anxious, as many kids are when they tantrum. I've definitely heard this from some of my own patients, and I'm sure that I've not been their favorite person after I've taught their parents how to do this. However, I would actually tell you that it can be a lot more damaging to your rapport and a lot more disrespectful to your child patients to give their parents this type of advice behind their back. I'd also tell you that while having a good rapport with your child patients is really important, you don't need to be their best friend for treatment to be successful. And not only that, but treatment is unlikely to go very well if you only suggest things they like. I also think that being able to blame me for the parenting techniques they use really enables some parents to use them much more consistently and effectively. And when that's the case, I really don't mind taking the heat for this, and having, some minor rupture in my rapport with my child patients. Usually it can be repaired fairly easily if they're angry with you. Now, when I teach parents this ignoring technique, one thing I always talk about is something called extinction burst. I would tell you that it's actually really, really crucial to warn parents that their child's behavior is actually going to get a lot worse before it gets better when they employ this technique. Basically, behavior research has shown that if a rat gets a reward pellet for pressing a bar, and we suddenly stop giving that rat that pellet for bar pressing, he's actually going to press that bar more and more and more vigorously before he stops in the hopes that a reward will come. Similarly, if we stop reinforcing a child for acting out by paying attention to them, that child is going to scream louder and longer before they stop reacting in this way. And this is called extinction burst. And if you or parents see the child screaming louder and longer, it's actually a sign that you're doing something really right and that the child's behavior will soon stop. Often following this extinction burst, it stops pretty abruptly, and it usually takes about 2 weeks of doing this consistently before the tantrum stops, sometimes shorter, sometimes longer, depending on the kid. But when I see this extinction burst, I always kind of celebrate it, and I tell the parents to celebrate it as well, and it's something that they should feel encouraged about. Now, of course, though, if you don't let parents know about this up front, you are almost guaranteed to get upset and angry parents in your office telling you that what you've suggested doesn't work at all and, in fact, has made things a lot worse. So definitely talk about extinction burst when you're introducing this technique. Now, sometimes when I teach parents this ignoring technique, they express worries about their children damaging property or hurting themselves with objects. They worry that if they don't placate their child, the tantrum will really escalate to the point of violence. And in a lot of cases, I would tell you that this concern is largely unfounded. However, if it does seem like a realistic possibility, I recommend that parents either remove their most valuable or dangerous objects from, the setting where their child is tantruming, or from, settings where they know their child typically tantrums, Or if their child is small enough that they move their child at the very beginning of the tantrum into a space where there isn't much to break or hurt themselves with. Again, moving their child with as little talking as possible, as little eye contact as possible when they do that. And I tell you, I've actually had kids tantrum pretty violently in my office. And while I, of course, don't want them to break anything, I know most of the stuff I have in here is easily replaceable and not dangerous. So when this happens, I just pick up my laptop and I pick up the scissors on my desk and I go stand outside the treatment room with their parents until the child calms down. And this is actually, you know, a really great thing if it does happen in your office, because then you have an opportunity to model this behavior for parents and to really show them how this works. So another issue that parents sometimes raise with me is that they're really embarrassed to walk away or ignore their child when their child is tantruming in public. They feel like if they don't placate their child's going to make a really big scene. And it's true that letting a tantrum continue can be really embarrassing. I've experienced that with my own child. This is not an easy strategy to use. However, as long as parents continue giving into tantrums in public, they're going to continue to happen in public, even if they stop happening in private. And what I tell parents is that this can be much more embarrassing and distressing in the long run if you keep having those scenes than going through a few weeks here of letting those scenes play out. So when parents are in public, I advise them to not only ignore their child themselves, but also to try to prevent others in the environment from providing their child with attention and reinforcement either. So if others express concern about what's going on with the child, I coach the parents to just calmly tell them that their child is in timeout and to ask them to please ignore their child. Now, a final issue that sometimes comes up is that kids sometimes tantrum with other people besides their parents, like with grandparents or with babysitters. And when this happens, either you or the child's parents are going to need to work with these people as well to make sure that they're managing tantrums in the same way. Otherwise, tantrums are likely to continue with these people even if they stop with the parents. Now, sometimes parents also punish tantrums by taking away privileges. And I tell you that generally, if the tantrum doesn't involve hurting anyone or damaging anything, we recommend just ignoring it. Applying a punishment in the middle of a tantrum in particular can really prolong that tantrum by giving it attention. However, of course, if the tantrum does involve something like breaking something valuable or hurting someone else, of course there needs to be a consequence for that. So what I do is I instruct parents to just let their child know in advance that there's always going to be a consequence for things like hitting or breaking things, whether that behavior occurs in the course of a tantrum or when the child is not tantruming. And then if it happens in the course of a tantrum, I coach parents that they should enforce the consequences to that behavior after the tantrum is over rather than shouting it out during the tantrum.
So speaking of punishment, we are going to be talking about removal of privileges as the behavior management strategy throughout the course of this presentation. Therefore, I also want to briefly review some general guidelines for applying negative consequences. First, punishment generally works best when it is used to discourage kids from doing unwanted behaviors like name-calling, hitting, or throwing. If instead you're trying to increase positive behaviors like doing their homework, then rewards are much better motivators. Second, when the parents apply punishment, we recommend that they do so without a lot of explaining or talking. Remind them to just be clear and concise. Of course, children should know what they did to warrant a punishment, but children are not mini adults, and talking in detail about why something is wrong is generally not an effective strategy for reducing bad behavior. In fact, these kinds of discussions often tend to make angry kids angrier or more frustrated. Finally, if the child is engaging in a behavior that they're trying to discourage, we recommend that parents use a counting system to encourage them to stop. In other words, if the child is doing something like teasing a sibling, we recommend coaching parents to count, saying, "That's 1, that's 2, that's 3. And if the patient doesn't stop the behavior by 3, then immediately apply a punishment. We advise that parents don't explain what the child is doing wrong between counting. They'll quickly learn that if you're counting for it, you don't like their behavior. And that if their behavior becomes physically aggressive, like hitting, we recommend parents immediately go straight to, that's 3, you're in timeout, and apply the consequence. So those are our recommendations for applying punishment. Next, we're going to talk about more specific behavior problems that often come up for children who have an anxiety disorder.
Okay. So one problem that often comes up for kids with anxiety and significant anger is treatment refusal. Either refusing to come to session at all or refusing to participate with exposure and response prevention. And some people assume that if a kid is refusing to participate in outpatient treatment and talking to their parents and having their parents talk to them doesn't work, it means that that child just can't do outpatient treatment or needs to be referred to a higher level of care. However, when a child refuses treatment, we actually still have a lot of options. And as long as you can get their parents on board, outpatient treatment can still be really, really successful. First, we can use both rewards and consequences to try to motivate the child to come in. And obviously, since coming into session is, a behavior that we want to encourage, we want to start by using rewards. Like Julianne said, we start with rewards when we're trying to encourage a positive behavior. Children can earn points, stars, or other tokens to be used toward prizes of their choice, not only for doing exposures, but just for coming into session period or for coming into session without protest. I'd also tell you that I try to bribe kids pretty liberally with candy, games, and other things they like that we do in session to try to motivate them to come in. However, if rewards are not enough to get a child in the room, you can also set it up so that they have to earn the right to things that they might normally take for granted by coming in for treatment. Things like the right to use their cell phone or the right to play video games. Finally, if the removal of ordinary privileges is still not enough to get a child to do treatment, we occasionally recommend taking a more extreme approach. And I'll preface this by saying I don't recommend this approach in all cases. This is probably not an appropriate approach for a kid with a mild anxiety disorder that doesn't cause many problems for them or their family. But when the alternative is the parents dragging their child to a residential care facility or watching their child continue to suffer with something pretty severe, this option that I'm going to talk about is really something to consider. So the fact of the matter is that children can actually lose the right to all privileges. TV, video games, phones, time with friends, books, snack foods, clothes they like, mattress on their bed, etc., until they come in or do whatever exposure we would have been doing in session that day with their mom or dad. And I tell you that as harsh as this sounds, children are not entitled to anything but 3 square meals a day, basic clothes, and a roof over their heads. Everything else we give them is a privilege and something we give them because we love them and we want them to be happy. But if a child's anxiety is really a problem and we can't get them into treatment any other way, then parents can make their home like a boot camp and basically remove all incentive for staying home and not coming to treatment if need be. And in my experience, this strategy tends to work rather quickly. Most kids don't hold out for more than a few days under these conditions because it gets really boring for them. If you worry about this leading to increased depression or anhedonia, I would tell you that this is not really an issue because usually this does not last more than 24, really 40 hours. I'm hearing some feedback on your end again, Helen, I think, or someone's microphone. If you guys could keep that down. To go back to this technique, the other thing I should let you know is that even though this tends to work rather quickly when you do it, when you're dealing with a kid who tends to refuse things like treatment, parents often have to apply this strategy multiple times before their kid consistently gets to the program. For example, last summer I worked with a 14-year-old girl who not only was refusing to come to our sessions, some of the time when we were doing particularly difficult or, things she didn't like, but she also had been refusing to attend classes at her therapeutic boarding school before she came home for the summer, and she was refusing to get up and out of the house sometimes in the morning, to get to other commitments she had, like dentist appointments. And her mom had to use this strategy several times during your work together. And my patient always caved within about 24 hours each time her mom did this. Yet it still took her mom, a good couple months of doing this before she could get her daughter to the point where she didn't refuse things like this at all. It took my patient that time to learn that her mom was going to consistently apply this strategy. And that refusing things just really wasn't an option anymore. And on a side note, I'll tell you that even though I was the one suggesting this strategy, and my patient very clearly knew it, when she did come into session, we were always able to work pretty effectively together and had a pretty good rapport in the session, even though she did not like what we were doing some of the time. Now, in addition to using rewards and consequences to get patients into the office, we also recommend just bringing the session to them if they refuse to come to you. And at least at our treatment center, we do offer in-home sessions. And I would tell you, if you don't do this, that this is actually ideal for some conditions, like certain types of OCD, whether or not your patient is refusing treatment. Now, of course, if you show up at someone's house, their child may still not want to participate in treatment. So we recommend that you try to get them on board in a few different ways once you show up. First of all, you could try working with parents and talking about the child's difficulties and your plan for treatment in front of the child. If the child refuses to come out of their room, do this right in front of their door and talk in a loud voice so they can hear you. Sometimes this alone is enough to get the child out and talking. No one likes to hear other people talking about them without their input. The second thing I'd tell you is that you should definitely talk to the child, even if they won't talk back. And what you want to do is label their refusal behavior as fear behavior, really just being scared. And I try to do this with my patients in an easygoing manner, and I express confidence that they can get over their fear. Now, finally, the other thing you want to do is you do want to explicitly point out to the child why their cooperation might be advantageous. Fact of the matter is that they can better help you figure out their anxiety if they talk. Of course, they could just let their parents do all the talking, but even the most perceptive parents make mistakes. And you should gently let your patient know that even if they choose not to talk, they're still going to have to do things. Exposures and going along with bans. And they'll have to do this without the advantage of their input about where you guys start. Now, if none of this works to get the child on board, I tell you that all is still not lost. Some sessions, we may not even need the child. We can always do a parent session focusing on behavior management and creating plans for exposures that they can do with their children. Or, if necessary, ways that they can prevent their child from engaging in compulsive behaviors or safety behaviors in the home. And for some types of anxiety and OCD, we can do exposure without the child's help at all. For example, if you're working with a child who's afraid of poop or germs, we can easily contaminate that child's space and force them to be exposed to these things without their help. Now, sometimes, of course, treatment refusal is a lot less extreme than what I've been talking about. A lot of the times, kids are perfectly willing to come into the office and participate in treatment generally, but then refuse to do particular types of exposures either for us or for their parents at home when we assign homework. And as we've mentioned before, we first try motivating kids with rewards or points towards rewards, and then we use consequences if that doesn't work. And when we're talking about a child refusing to do an exposure, consequences can either be the removal of privileges, or they can be things for exposures in and of themselves. For example, we recently treated a little girl suffering from severe religious-based OCD or scrupulosity, And each time she refused to participate in an exposure that we asked her to do, we would have her mom donate $1 to the American Atheist Center. And we emphasized that by choosing not to do the exposure, she was actually the one making a choice to have her mom donate. And making this sort of choice, of course, went against her religious beliefs as well, and was an exposure for her as well. So sometimes you can use, other forms of exposure as a consequence as well. Now, sometimes you'll suggest or try out all the strategies that I've gone through, and you still won't be able to get a child to fully participate in treatment or do all the exposures they need. For example, if either parent is unwilling to commit to using rewards and consequences, they're unlikely to be very effective. I tell you that I've had that happen, some of the time with parents who are divorced or divorcing, or who are just not, very in sync about using these strategies, and that can make it really difficult to get the child on board. Additionally, there are some cases where you really do need kids and teens to actively participate in the exposures you're suggesting. And every once in a while, you'll encounter a patient for whom rewards and consequences are just not motivating enough to get them to face their fears, even when parents use those rewards and consequences really consistently. And when this happens, this tells me that the child's anxiety is particularly severe, or that they're experiencing particularly significant anhedonia. And in such cases, if the child isn't already on medication, I often refer parents for medication consultations, and sometimes that can help. Sometimes, we can go back to the drawing board and try these strategies again once a child is on medication if they were not before. If none of that works, then it might be time to think about referring to a higher level of care. So now I'm going to turn it over to Julianne, who's going to talk about managing school refusal.
All right, so going off Allison's discussion about treatment refusal, when parents bring in their child for treatment, it is common for them to display problems with going to school. Typically, their behaviors are happening at home or in private, but there are definitely situations that provoke their anxiety at school. Like most children, they may be well behaved at school but decompress at home, and they tend to act out more there. We actually do see a lot of kids who have troubles going or staying at school because of their anxiety, and it is one of the main reasons for why parents bring in their child. Usually they have unsuccessfully tried to get the school staff or counselors involved, but they don't have the proper resources to intervene. So the child has trouble going to sleep, has a hard time with getting to school the next morning, staying in class, or completing their homework because of their anxiety. It is very important to work with the parents and the school to set very clear guidelines about when the patient can miss school. And I mean very specific and clear guidelines, because these children can be very perfectionistic and exact and rule-driven. If the child also is on the spectrum, you will need to be even more concrete. We recommend parents follow the American Academy of Pediatric Guidelines criteria, which is that in order for a child to miss school, they must have a fever with a temperature of 100.1, repetitive vomiting, and repetitive diarrhea. It is important to pay close attention to what may be causing the child's symptoms and suspect that anxiety may be the culprit. It is also important to find out what behaviors the teachers, the school counselor, and the school nurse see, so you want to get access to feedback from the school staff. Interestingly, I have had situations where parents actually needed to convince the school nurse to keep their child at school because she would give in to the child. Each time the child would run into the nurse's office complaining of feeling sick, they would call the parents to take the child home. Getting this type of information is important because you want to know how much of the child's anxiety is really messing things up for their life. And if needed, you may need to advocate for the child to get accommodations so it's easier for them to manage their anxiety while at school. Accommodations may include needing time and a half on tests, taking a test in a separate room, or needing extra time to complete homework or projects. So here are some statements that may sound familiar. I can't go to school, I'll get sick, I'll get in trouble, I'll have a panic attack, lose control, and be embarrassed. What if something bad happens to me or my family while I'm at school? These are just some of the common concerns that anxious children have, and there are several other types of concerns that are not on this list. Sometimes there are cases where the patient cannot identify why they feel anxious. They are unable to pinpoint what makes them anxious about school. But it is important for us to understand that the patient's fears are real to them, and they truly believe that they must do everything they can in their power to avoid feeling anxious. So what do we tell the kids to do or to say to themselves when their anxiety is bugging them? We tell them to just say no to their anxiety. Coach parents to use forced choice using the concepts we discussed earlier, using rewards or consequences. So what does this sound like? Look Sally straight in the eye and very matter-of-factly say, Sally, I know you're scared to go on the bus, but you need to go to school. Now, I could take you to school, but if I do, I most likely will be late for work, be behind on my paperwork, and may get home later at night. So you have two options. You can either have the bus pick you up, or I will take you to school, but won't have time to watch TV with you because I finished work late. Or for the parents who both work long hours, Sally, I know you don't like taking the bus, but the problem is Mom and Dad have to work at 8 a.m. and we need you to go to school. So you have two options. You can either take the bus with your friends and be at the bus stop at 7:30 a.m., or Grandma will have to take you, but since she's a little older and drives a little slower, you will have to leave at 7 a.m. instead. It's your choice. If the child is repeatedly unresponsive and the parents are unable to verbally encourage them to go, you will need an extraction plan to physically move the child from the house to the car or from the car to the school. You need to put together an extraction team. For small children, this could just be Mom and Dad. For bigger children, you may need 3 to 4 people to ensure that you're being safe. Sometimes a school staff or police escort coming to the house or greeting at the car when getting dropped off is useful. So check with the school first to see if they offer these resources. Whatever plan you go with, whether it's the forced choice or the extraction team or both, you want to remind parents to not only follow through with what they say the outcome will be, but also stay consistent and do not give in to the child's tantrums or threats. So these are actual items that have been used by some children we see as a way to threaten their loved ones to give in to their anxiety. So we see a little girl with a knife, the boy with a hockey stick, and the girl holding a plunger. Out of desperation, an extremely anxious child might use these so-called weapons and are very strategically and cautiously using them to threaten their loved ones. They rarely are actually intending to hurt anybody. They're desperately doing all they can to prevent their fear from occurring. However, these children are making very dangerous attempts in order to be the hero. So let's talk about implementing the extraction plan. How are the parents going to get the angry child to get out of the house, into the car, and then into the school? The best time to do this would be at the start of the week, Monday. So first, remind the parents that the tantrums will get worse before it gets better. It will also feel worse for the parent and the patient before it gets better. I even had a mom refer to her extraction plan we created for her daughter as DEFCON 5. The next thing is to make sure parents do a quick sweep of the house to eliminate any potential objects your patient will use as a weapon. Have the child's clothes picked out the night before, have their lunch already made and their backpack packed. Parents must eliminate any items that would make it harder to get the child out of the house. And therapists who do home visits can go through the house and point out the items that must be eliminated. They must also remove anything else that may be reinforcing in the house that would make the patient want to stay home. So no iPads, Xboxes, computers, TV. Tell parents to lock these items up or keep them in the trunk of their car when they're going to work. Also, make sure the child's voice doesn't overtake the parent's voice. Remind parents to not let their child's fears or behaviors scare them away. The parents are the boss, they're in the driver's seat, not the child. Anxious children tend to be very smart, strategic, and creative, and they can be quite sneaky. They are likely to put their parents' own anxiety or fears to the test as well, not because they are bad children, but because they are extremely, extremely scared. If the patient has to stay home, we recommend that parents do everything they can to make the environment boring. Removing access to electronics may not be enough. changed the password to the wireless, and removed the cable cord to the TV. When escorting the patient to school, it is more helpful for both parents to be involved and both take a proactive rather than reactive approach. It is helpful for you to coach the parents through how to safely extract the child from the home to the car and from the car to the school. So let me give you an example of a case we had at our practice. A couple of years ago, we were working on this intensive with a 13-year-old boy. I will refer to him as Robbie. Robbie weighed probably around 125 to 150 pounds. And because of his agoraphobia and panic attacks, he was reluctant to leave the house and into the car and from the car into the school. Because of Robbie's weight, we had to call in 4 therapists to come to the home. He woke up, he had breakfast, and we arrived at his home. Up until the point where his mom asked him to grab his backpack, he was fine, and then he froze and refused to go out the door. So we gave him forced choice. Either you walk out of the house, Robbie, and into the car willingly, or we drag you to the car. It's your choice. You have 3 seconds. Robbie refused, so we had one person safely gripping under each of his arms, and then each person safely gripping each leg. Once he felt gripping, he chose to angrily walk out of the door and into the car. Mom gets into the car, and we drive behind them on the way to school, and then we waited for the bell to ring, then parked the car by the school entrance. We quickly realized that Robbie was refusing to get out of the car, so we had to use the same extraction technique to get him out of the car. While the goal is always to get the kid quickly from the car to the school, that's more idealistic than realistic, because keep in mind that Robbie was quite heavy and pretty much had a death grip on the car seat. It took around 2 hours for us to get him out of the car, and he was pretty much waiting it out to see if we would give up. But when we finally were able to remove his grip on the chair, he angrily got out of the car to outside. And after one quick verbal prompt to get into the school or else we would drag him again, Robbie walked quickly into the school. To speed up this process, we strongly recommend that parents use points towards some type of reward for engaging in specific behaviors aimed towards getting the patient up and out independently. So for example, if a patient wants to get points towards an Apple gift card, they can earn the money towards the card using points. So in the case example we used, we would give Robbie 1 point for leaving the house and getting into the car on his own, and 2 points for leaving the car and getting into the school, and a bonus point for getting into school within 5 minutes after the bell rings. So at our clinic, we have a way to safely extract the child. So the way we would do this is that we would drag or lift the child where there is an adult, preferably a parent or a therapist, on each side of the child, hooking their elbows underneath his arms. And then we would lock the child in place using the sides of each person's hips, pressing against the side of the child's hips. If the child is bigger or squirms around a lot or is kicking, you may need 1 or 2 people, more people, to grab each of his legs in order to do a safe extraction. So set up a welcoming team with school staff to greet the child when he or she gets dropped off. They can escort him into the school and have him stay in the office until the bell rings. The child can meet with the school counselor in the middle of the day just to check in and get support. The counselor can also provide quick reminders to do their exposure practices when their anxiety is bothering them. So that's the extraction plan. In order for this to be effective, you want to make sure that parents have the energy and willpower to follow through. Consistency is essential when proceeding with this plan. Reassuring your patient is not effective. Remember that after a long day of school, kids are tired and stressed, so no wonder why we see them act out more at home. The goal is to teach these kids to tolerate uncertainty, to take risks, test out faulty thinking, and to learn to be resilient. The therapist's task is to give the parents, the child the skill set needed to help the child grow and to be an effective adult. So when the child's anxiety is holding them hostage, they may start to make threats. Overall, the risk of suicide increases if the child has poor impulse control. And the real question here is, when a patient with anxiety threatens to hurt themselves or others, what do they actually mean and what do you need to do? On some occasions, we've experienced certain times where a child threatens to hurt themselves, or others, other parents may allow it. I've personally had patients threaten to kill themselves when they knew I was coming to do an in-home session to have them do exposure. On some occasions, people have discontinued treatment prematurely because they are frightened that the child is making these threats. I had a 13-year-old boy threaten to hurt me if I put one of my feet in his bedroom because he was afraid of me making it dirty. More often than not, these kids will say these things in order to get what they want, which is not to do exposures. You want to coach parents to figure out what the child means specifically when they make threats to hurt themselves. So have them ask, do you want to die, or are you just upset, afraid, or scared? And if they actually say they want to die because they're feeling hopeless as a result of their anxiety, then this is to be taken seriously and you will need to do a risk assessment. If they say they feel they want to die in response to you not allowing them to avoid the situation, then it most likely is them trying to get out of doing exposure. There's a difference between words and actions, and just because they want to do something doesn't mean that they have to act on it. So help the child and the parent understand this misconception and help the child come up with more effective ways to express how they feel. Some kids have an especially hard time identifying and expressing how they feel if they have a learning disability or a developmental disability. So sometimes anxious kids may make threats to hurt other people like siblings or their parents. And one reason they might threaten a loved one is because they might feel like they have to intimidate them to get out of doing exposure. Siblings already poke at each other, tease each other, and bicker a lot, but this will happen more often if the patient is anxious. When faced with a kid who has harming fears that something bad would happen to mom or dad, for example, anxious kids may attempt to kick, slap, punch their parents as a way to eliminate their fear that something bad would happen to their parents. I was seeing a 9-year-old who felt like she had to kick her mom just right whenever she was upset because she was afraid something bad would happen to her mom or her if she didn't. For a patient who has anxiety, this may happen more frequently because they are trying to protect themselves or their loved one from some feared consequence. Another reason anxious kids may threaten to hurt other people is because they may actually feel hopeless, angry, and desperate. We've seen cases where the patient would threaten to kill their parents if they didn't give them reassurance that they were contaminated or not. So how do you tell whether your patient is trying to intimidate you or if they're an actual physical threat? Well, this can be really hard to assess and will vary for each individual case. But typically, if the child actually attempts to physically harm someone, you will need to take precaution. If the child repeatedly makes threats and the person they are threatening tends to give in, then you see the patient playing happily immediately right after, then they most likely were trying to get out of doing a really uncomfortable exposure. So what if the child is not making threats but actually does end up hurting someone or some themselves? Despite what difficulties or how severe the anxiety symptoms are, there is no reason for the child to hurt themselves or another person just because they're anxious, upset, or angry. It's important to use timeouts by either removing them from the situation or taking away something they enjoy. You also want to make sure to eliminate any access to items they would use to hurt themselves or others by either putting them in a separate room, taking away any potential access to weapons, or having to do a safe restraint to prevent serious harm to themselves or someone else. The therapist could also teach DBT skills like emotion regulation, distress tolerance, mindfulness. Relaxation techniques and communication skills can be used to help them manage their emotions more effectively. I personally like to use progressive muscle relaxation or diaphragmatic breathing skills to help kids manage their responses to their physical sensations. If there is a repeated actual attempt that the child makes to hurt themselves or others, especially if there are guns, knives, or serious injuries done to another person or self, well, then we have the parents call 911 or bring the child to the nearest emergency room. We find that some parents are reluctant to do this, but it is most important that parents send the message that they will ensure the safety of the child and the rest of the family. I'm going to skip over this, but these are some appropriate responses that we can coach parents to model when they're talking to their kids. And so the bottom line is that we need to send the message to the parents and the child that when anxiety tells them, come with me if you want to live, then we need to tell anxiety to stop bullying parents and the child. Parents can achieve this by being empathic but not give in to their tantrums. It is not the child, it is their anxiety.
Okay, so that's it for our presentation today. At this point, we're going to take questions, and it looks like Helen has been typing some of your questions into our chat box. So the first question here is, can you elaborate on what an extraction might look like for an older child? How do you respond if the child becomes combative when you're trying to lock arms? You know, I think actually Julianne described that one pretty well. You know, with the case of Robbie, an older, bigger kid, we just bring in more people, basically. And then, let's see, next question. What about kids who hit themselves during a tantrum? Okay, so good question there. So first of all, you want to assess how serious this is. Sometimes when kids do things like hit themselves or pound their arms on the floor, you know, it's not really that big a deal if the kid is not actually causing injury to themselves. You know, if the kid actually is injuring themselves, you know, there's only so much you can do without an object, so you do want to be removing objects. If, you know, they are still injuring themselves just with their hands there, that's where that safe restraint that Julianne talked about comes in, and you know, that's easier to do with a smaller child than a bigger child, but to you know, hold the child in your arms without talking to them, without looking at them, to lock their arms in place, you know, to sit on the child, you know, if you need to, or sit on their arms. You know, that would be the approach I would take for that. You have any additional thoughts about that?
That was exactly what I would say.
Okay, and then next one, what do you consider an appropriate consequence for an 11-year-old child who loses emotional and behavioral control to the extent that she hit or kicked her mom? Any thoughts?
I think that typically whatever is the item that they are enjoying the most, like their phone or their iPad or the computer, would be a good consequence for the kid. It's just a matter of figuring out what is it that would really get the job done, what would really make them bothered by the fact that they're losing something.
Absolutely, and you know, the other thing, of course, is obviously more severe consequences if we're getting more serious injuries here. Okay, next question. What about school refusal due to anxiety and depression when the parent is inconsistent and non-assertive? Do you want to take this one?
I think that it's usually just very difficult to work with the kid if the parents are not consistent. So I might spend the whole session just with the parents talking about how consistency is really important, and that if there's a lack of follow-through, then we can't guarantee that the kid is also going to follow through. So the parents need to follow through just as much as the kid does. And I might be working with the parents just to role play, you know, how to respond in situations where they're having difficulty, and have them do that several times in the session, and then practice it outside of the session, and then come back and tell me how it went. And I like to have parents give each other praise, and also have them grade the other parent on how well they were able to follow through. That usually helps with making sure that they're holding each other accountable.
Absolutely. You know, and this is a really tough situation, and you know, I've had to have multiple sessions just with some parents to deal with this, because it's, you know, you don't need the kid on board to do this sort of treatment, but you do need the parent on board. And sometimes that means doing some cognitive work with them. Sometimes it means, you know, the behavioral rehearsal that Julianne talked about. So are those all the questions that we have? Are there other questions that we can answer in this last minute or so here? Okay, so it looks like those are all our questions. Great, perfect timing. So I'm going to flip the slide so that you guys can get that all-important continuing education code. So it's PRAQ. So thank you all so much for attending the webinar today, and I hope that you can really apply these to make your practice better.
Yes, thank you so much, Allison and Julian, and thank you to our participants for attending today's webinar. You will receive a follow-up email within an hour that includes a link to the evaluation and a link to the recording of the webinar. Please share your thoughts even if you are not requesting CE. We hope you will join us at the ADAA conference this coming April 5th to 8th, 2018 in Washington, D.C. On behalf of ADAA and our presenters, thank you for joining us today, and have a great rest of your day.